start at the beginning, I would go further to, we have mentioned the guideline from ESC, yes, and so about the worldwide experience. One of the first papers about ECMO as bridge to decision was published by Bowen and co-workers in 2001. They supported 23 cardiogenic shock patients with ECMO. As a result, they have saved 43% of the patients. One of the first reports of chronic heart failure patients supported with ECMO in cardiogenic shock was published by Dr. Permudes and co-workers. They have presented 42 patients, 9 of them were chronic heart failure patients. They concluded that the support of acutely decompensation chronic heart failure patients is extremely challenging. Another publication was presented in 2016 from Dr. Marasco's group. In their cohort, there were 11 acute decompensated chronic heart failure patients. They have shown that results are quite comparable of ECMO support as bridge to decision than results of LVAD implantation in Intermax-1 state. Dr. Tarzia and his co-workers presented a paper about their ECLS results in 2015. 27 patients of more than 200 ECMO supports were chronic heart failure patients in their cohort. 56% of these patients survived. They concluded in their report that ECMO is an ideal option to reverse cardiogenic shock in chronic heart failure patients, ideal because it can be inserted easily and rapidly, which is an important advantage. Among many conclusions, one should be emphasized. In average, the VA ECMO support duration was 7 days, but after 9 days of support, the risk of death is increasing day by day due to higher complication rates. We find valuable results as well in the ELSO Registry about ECMO support in chronic heart failure patients. Here we can see that 51% overall survival was achieved. Dr. Cheng and co-workers published their results in 2017 about ECMO support in chronic heart failure patients. They treated 29 such kind of patients. They demonstrated that organ functions improved quite well during ECMO support. They marked the utility of the ECMO device. Short insertion time is a great advantage of ECMO compared with other device types. They concluded that support duration should be as short as possible to avoid potential complication of ECMO support. Dr. Habal and co-workers have excellent survival results in ECMO support of acute decompensated chronic heart failure patients. Here we can see they reached 68% survival in this patient group. The biggest patient cohort in our topic was published by Dr. Tarzia. They supported 105 acute decompensated heart failure patients. Their overall survival was 42%. However, better results can be achieved in patients in whom the pre-ECMO status is better according to the SOFA scoring system. Are there any other possibilities with short-term MCS for that patient group? Some papers have been published already about impulse support in that patient group with different results. Let me present you our experience at Semmelweis University. We have started our ECMO program in 2012. Since then, we have treated 32 acute decompensated chronic heart failure patients as bridge to decision strategy. Mean duration of support was 6.8 days in our institution. Here are some data about our patients. 60% of the patients were in Intermax-1 state. ECMO support was initiated during CPR in 30% of those patients. Main etiological factors of the acute progression were 37% acute decompensation, 30% arrhythmia, and 17% infection. What was our strategy in our institution? After insertion of VA ECMO, we continued the therapy either with MCS and then heart transplantation or direct with heart transplantation in one case. In 3 cases, we experienced recovery after ECMO support. We lost 7 patients during ECMO support. Long-term survival was 53% in our cohort. We divided the patients in 2 groups. First was chronic heart failure patients. Second group was end-stage heart failure patients on the waiting list. In the first group, survival was 56%. In the second group, we have survival from 44%. If we compare the survival of our entire heart transplant patients in the last year, our institution performed about 300 heart transplants. We can conclude that ECMO bridge patients have a comparable long-term survival as the average end-stage heart failure patients. Dr. Caballero and co-workers have shown quite similar results in heart transplant patients, heart transplantation survival in patients after ECMO support. To conclude, we can say ECMO can be used as bridge to decision therapy for chronic heart failure patients with relatively good survival results. ECMO can be initiated quickly in a decompensated patient and limit the amount of time of inadequate organ perfusion. ECMO therapy can stabilize and improve organ function during support, and ECMO as a short-term MCS is a realistic and cost-effective option to reverse the patient from refractory cardiogenic shock state. Thank you very much, and thank you very much once more for the opportunity.
Thank you very much, Miklaus. I think it's almost time for a conclusion of this very nice session. It was a real pleasure for me to moderate this session with you, Thomas. I would like to thank all the speakers.